thank you for coming. Thanks for having me, and also thanks for having me the last 9 years. I've been seeing residents here since the beginning of 2013, and
Where are your,
I see patients at St. Mary's and Elizabeth's Hospital. That's like Bucktown, Wicker Park, Ukrainian Village. Those the two hospitals that are there, and I've been there forever.
Can
But-
everyone hear?
Oh, no.
Your mask off.
It's okay.
You're the only one that can.
Okay. All right. So, what I'm going to talk to you about is dermatologic problems that commonly affect older people, and that's what I've been seeing. And I'm going to actually show you pictures of conditions that you may have, you might have in the future, but certainly I think pertinent as we go forward. You'll see that you can relate to some of them. This is a little bit about me. I'm a dermatologist, and I went to Cornell and Harvard for my medical degree, and then did my residency there. But I want to point out that my junior year in college, I went to Syracuse University as my junior year abroad. They had an all-university gerontology center there. I thought I was going to be a geriatrician because I had interest in older people and medicine, and that was seen to be obvious for me to do. No, in Syracuse, New York. But it turned out I got to medical school. I got to my dermatology rotation and got there. Everyone was happy, and I said, I think I want to be a happy doctor, and so I decided to do dermatology. But now I'm coming full circle. Now part of my practice is seeing older people, and that's basically where I started thinking about medicine. I make house calls to residents of senior buildings. I go to assisted living facilities as well. That's in Chicago and also in Vernon Hills, where I was working for a while, so I developed a practice there. I usually go there one half day a month, so I'm there every single month on the second Wednesday, third Wednesday. Here I'm here the second Tuesday of the month, and I'm pretty consistent with that. So dermatologists diagnose and treat problems of the skin, hair, and nails. Show you a bunch of different conditions that I've seen. I also can do procedures in the apartments. I can do biopsies of suspicious lesions. I can treat bothersome lesions by freezing them off, like wart-like lesions, things like that.
Mohs?
And no, Mohs, the question was, can I do Mohs? We'll talk about that later, but the answer is no. Okay, so here are problems that I'm going to talk about today. I'm not going to talk about problems that you may have had all your life, like psoriasis. I'm going to talk about specifically things that pop up or are more common in adults and older people. So first, why is the skin the most important organ in the body? It's the largest organ. It holds everything together, but it does a lot of specific things, such as protecting the bones and the muscles. It's a relative blood reserve. It protects us from the sun and ultraviolet radiation. It's an immune organ, so a lot of times we're exposed first to things that we mount an immune response with cells from the skin. It regulates our body temperature and prevents water loss. And also, it's a neurologic organ in that, we have to feel things to pick them up. We feel hot, cold, things like that. It produces vitamin D with the help of the sun. And also, it excretes sebum, again, to help protect the skin. Dry skin or xerosis is probably by far the most common thing that I've seen. Probably everyone here has dry skin, especially of the legs, especially when it was the middle of the winter. Hopefully it'll get better for everyone as time goes on. And treating dry skin is important. It can be itchy, it can be unsightly, it can be just a little bothersome. Why else is it important? Well, once skin dries out, it's more susceptible to becoming inflamed or dermatitic. And so This is a picture of the feet and or the ankle area and the back of the leg in another patient where their skin got thickened, it got reddened, itchy. You can see scratch marks, and this can even go on to problems where you get cellulitis, and that's probably a word you've heard in the past. Someone had it, you had it, and that's when the fat actually gets infected, and that's bacteria that's getting there most likely through the skin. So think about the dry skin that this might have started like. If you kept the skin as intact as possible, it might have prevented eventually an infection through the skin to the fat. Seborrheic dermatitis or very bad dandruff, this can occur in the scalp, obviously, we all know is dandruff, but scaling on the face, scaling in the ears, scaling around the nose. And this is, again, something if you can control it early with very mild hydrocortisone preparations, like the 1% that you can get at Walgreens. Eventually, you might need a little bit more strong cream to treat this, but very common in older people, adults and older people. Rosacea is a problem that not only is on the skin, and you can see it as pimples and redness and little blood vessels, but it may have been preceded or accompanied by flushing and blushing. So you'll be out in the sun and you get red in the face, or you are stressed out, you get red in the face, or different foods like cheeses and alcohol and exercise can induce this. And so it presents itself over a number of years, and eventually there's long-term damage in terms of the blood vessels and sometimes the pimples. The treatment is topical treatment usually when it's severe, maybe oral antibiotics. Yeast infections or candidiasis, it happens in skin folds, under the breasts, in the groin, and under the stomach, and again, skin, and that's what causes this. It sets up an environment where the moisture, the heat, the darkness lets yeast grow, and yeast is everywhere. And usually it doesn't like to grow just on our skin by itself, but when it has the environment that it likes, it's like a culture media, and it'll just take off. And again, this can be treated and prevented with a topical antifungal, and rarely we need to use pills, antifungal pills. Seborrheic keratoses are stuck-on lesions on the skin, almost like barnacles on a ship. They don't hurt your skin, they don't hurt you, but sometimes they can get inflamed and itchy, especially if they're in areas that are rubbing, but with clothing or even on your back if you're sleeping on them all the time. And when they get red and a little bit irritated, like the one on the right, you can freeze these off like you would do a wart in a kid with a very cold spray of liquid nitrogen. It destroys the skin in that area. It blisters up underneath and takes it up. Then it heals up. And sometimes it takes more than one treatment, but it's very effective. Periangioma. So if you look down at your stomach or in the mirror or your back and you see these little red dots, this is probably what it is. And they can be little red dots, or they can be larger to be like the size of a grain of rice or but not much bigger. Sometimes they can be a little bit larger, but most times they're very small, totally benign. You don't need to do anything about it. But again, sometimes they're an area that gets rubbed. So because these are made up of a lot of small blood vessels, you can imagine that if it gets scratched, it can bleed quite a bit. So sometimes we'll treat these again by freezing them off and destroying them with the liquid nitrogen. Similarly, skin tags, they can occur on the neck, underneath the arms very commonly. Again, totally benign, nothing you need to do, but they can get irritated too. So if you like to wear necklaces and you have skin tags, they can get twisted and get inflamed, and that would be a situation where we might want to treat them. And here we can treat them in a couple of ways. We can snip them off real quick because they're small, or we can freeze them. And I prefer snipping them if we can, because when you snip them, they go away and they leave literally no scar at all. When you freeze them, they can leave dark or lightening as a result of the healing process called post-inflammatory hypo and hyperpigmentation. So, but again, benign. They don't bother you, nothing to do. Lentigos or age spots or liver spots can occur in sun exposed areas. Uh, totally benign. If you have them on your arm and you look at the other side of your arm, you can see they're much less, and that can demonstrate how they are related to the skin. So what do you do with someone on the left where they have literally hundreds? There's nothing you can do. There's no cream that'll get rid of them. There's no specific treatment, or if they're, you could freeze them, and it may lighten them up, but you're not going to do 100 on each arm. Sometimes I'll say, well, is there one or two that really bother you? And they'll say, yeah, I'll be happy if this one and this one are gone, because I'm always looking. Then we may freeze them, with the caveat being, just like if you freeze a skin tag and it leaves behind a dark or light spot, you could leave behind a dark spot here and really trade one for the other. A larger one on the face, that's something we could lighten up if there's not, again, 1,000 of them, or if this is one in particular that bothers this patient. Moles, of course, everyone has moles, and I'm called to look at moles all the time. But here we see normal moles. And what's a normal mole? Well, a normal mole is a mole you've had forever and hasn't changed. That's a normal mole, just by definition. I don't really care what it looks like if you've had it without change for decades. There's nothing that's going to be concerning about it under the microscope. There's nothing that's going to be concerning about it to you in your life. And you can see these look all different. So moles can look just about anything, sometimes not even very dark, like the one on the lower right. And what you can notice of these, they're all very symmetrical, meaning if you cut them in half, one half looks exactly like the other. Even if you look at some of the borders are a little fuzzy or the pigment is a little different, they're very symmetrical. Keratosis. This is another sun-induced change in the skin where it's a little abnormal. So here, if you look under the microscope, you can see some abnormalities in the skin cells, meaning that they're not cancer, but we would consider these precancers. And these freeze off to destroy the abnormal cells, and then the normal cells that are from the sides will heal it up quite nicely. And if we don't treat them, some small percentage of these will go on to squamous cell carcinomas, which would require a lot more treatment. So when we see these, we freeze them, because usually one freeze is enough. And these are like scaly red spots that are on the face or the back or the arms or the ears. They sometimes can sting a little bit when you touch them. Sometimes you can feel them more than you can see them, meaning that their skin is a little rough compared to the normal skin. Here are some true sun-induced skin cancers, the basal cell and squamous cell skin cancers. And someone asked about Mohs. When these are large or in the face, we recommend they be removed by Mohs surgery. And what that means is the surgeon will remove it, and right away while you're sitting in the office, look at the margins. And if they removed it and there was no cancer seen at the margins, you're done. They'll stitch it up, go home. Let's say if you think of if the surgeon takes out a round piece of skin around the spot, let's say at 2 o'clock there was some skin cells there that were still abnormal with skin cancer. Then they'll go back to that area and just scoop out a little bit at 2 o'clock, and then look at that. And if that is clean on the margins, then you're done. If it's a little bit on that little scoop at 2 o'clock, they'll do a little more. So, but the end result is you're removing the minimal amount of skin as possible from an area like the face, which doesn't have a lot of extra skin. And also, the cure rate is almost 100%, because you're basically looking at the margins and they're clear. These are not life-threatening skin cancers. Very rarely a squamous cell, which is, let's say, that's been neglected and is, let's say, the size of a $50. They may have a very, very low but real chance of metastasizing. Sometimes a basal cell, which doesn't really metastasize, is in a sensitive area, and if it's neglected, will erode, let's say, through the bone with over years and years. So, but in most cases, totally benign, more of a nuisance to go down to Northwestern or wherever to the Mohs surgeon. This is the skin cancer that will cause a lot of morbidity and death, melanoma. Very easy to get rid of if you catch it before it metastasizes. You just take it out and it's gone, and the cure rate for thin melanomas that are completely excised, again, is 90% or more in 5 or 10 years. However, left unchecked, they metastasize, the chemotherapies are not great for this. So it becomes very quickly just trying to keep it down, but there's less chance of a cure if you don't get it if you don't get it before it metastasizes. So what's different here? Well, they're larger usually than your normal moles, very variegated in their color. Their borders are very abnormal. There can be ulcerations or erosions in them. Um, these can arise in a mole that you've had for years. So if you have a changing mole, that's important to get checked out. Photo aging, like wrinkles, you see on both these pictures, fine wrinkling, some deeper wrinkles. You see some of the age spots on the face. You see some lightening of the skin or yellowing of the skin. These are all signs of photo aging. That's both time and sun exposure. Um, and I don't do any treatments, any cosmetic treatments for wrinkles or these kinds of things. But there are lots of things can be done. There's Botox, there's fillers, there's laser, there's peels that can all improve the surface of the skin and its appearance. But probably the best thing any of us could have done when we were kids was just stay out of the sun, because that would have at least taken care of the ultraviolet light uh, over time. Nail problems, I show a picture here of both nail fungus and onychogryphosis, or old nails. Um, older people a little more susceptible to nail fungus because the circulation in the legs is not as good to keep the body surveilling for abnormalities and keeping the nails healthy. And they're already, because they're growing slower, more susceptible to the fungus that you see on the left. Treatment of nail fungus, really the only treatment that really works significantly is oral medication. So I very rarely will just give topically unless someone can't take oral medication, because you have to be with a normal liver, and some people just don't want to take a pill for this. It's a benign condition, and there's some side effects of the medication. So, but I can't be very encouraged when someone just uses topical cream for the nail fungus. On the right, old nails, I call them, as sort of like a translation of onychogryphosis, is the nails as we age grow much slower. That's why they're thickening and yellowing, and it's something which, well, the podiatrist knows how to shave these down, cut them, and make them as well as possible. So, um, so this is just an extreme example. Shingles. Now, everyone here knows someone who's had shingles, has had shingles, and what's the worst part of shingles? Pain, right? Pain, especially the pain that happens after you get better from the shingles eruption, because you can get this rash that you see, and then after it goes away, you think you're out of the woods, but no, all of a sudden now in that area, not only do you have pain, but it might be very sensitive to the touch, where you can't even wear clothing because it'll drive you crazy, or the bed sheets. Um, so something to avoid, and I'll get to that in a moment. So what is shingles? It's the reactivation of the chickenpox virus. So if you've had chickenpox as a kid, you can get shingles. You can't get shingles if you never had chickenpox. You can catch chickenpox if you've never had chickenpox, and you can catch chickenpox from someone who has shingles if you haven't had chickenpox or the vaccine. Um, but after the chickenpox rash resolves, the virus stays alive in the nerve ending, the nerves by the spinal cord. And as time goes on, as we get older and our immune system is coming down a little bit, and then all of a sudden it dips a little more temporarily, at that point, the body is not keeping the chickenpox virus at bay. It starts traveling up the nerve to the skin and basically causes the blisters that are similar to chickenpox. What's different, chickenpox happens all over our bodies because it's a systemic infection. Because this is just coming up one nerve, it only produces the rash in the distribution of the nerve, in the area of the skin where the nerve endings are, from where it started at the spinal cord. And that's why it's only on one half of the body, because each half of the spinal cord sends nerves to that half of the body. And it doesn't cross the midline, because that's the halfway point. So that's what you see on the right. And also you see on the left, where it doesn't really cross the center of the face. So not only is the pain after a shingles infection bad, but if it happens that you've gotten it on, and of course suffering through it while you have it, but if you get it on your face, and it can affect the eye and cause long-term problems. So that's another reason that this is something you want to get. And that being said, there's a vaccine now for shingles, which is pretty effective. It's 90% effective. And we talked about how our immune systems dip after a certain age. So now when they dip, there's antibodies that you've been enhanced with that then keeps the chickenpox virus in the nerve, preventing the infection and the sequelae of it. It's 2 injections in the arm, about 2 to 6 months apart to be effective for preventing the shingles infection. And you can imagine how any kind of virus, any kind of vaccine, whether it's the flu vaccines, you can get arm pain, you can get a reaction around the site, you can get the same things that you get with any vaccine: muscle pain, headache, tiredness. Um, but we'll probably won't get shingles. A good thing. I got mine. I have the second one coming. Okay, so as I said, I come here the second Tuesday of every month, and I'll give you the number of my office where you can call, and my assistant will collect your information and where you are in the building, of course. And probably from the presentation, you know reasons why you might want to see a dermatologist if things develop or that you have. But to review, any kind of new or changing lesions or new rashes that are bothering you, any sores that don't heal, that could be a skin cancer or just a sore that needs some help healing. Painful, itchy, or otherwise bothersome lesions. We talked about some of the spots that can be irritating, that are easily treated. Talk about it, but any kind of chronic skin condition like psoriasis that you have that you want some help with, obviously, I can help with that. If you have a history of skin cancers but haven't had like a full exam, that's another reason, because once you have one, you're more likely to have another. And similarly, a family history of skin cancers, especially melanoma, and any kind of scalp or nail problems. So the number is there, but I'm going to give you a sheet with that, and certainly the desk has it downstairs if you need me. And then if you need medications, I'll send them right to your pharmacy, whether it's the Walgreens or the Marianos. I can do that same day that I see you, so they'll deliver it, whenever their cycle of delivery is. Okay, well, that's the end of it, and so we have time for some questions.
I have very sensitive skin. I can touch something and it breaks out bloom. Calls about any of the masks or what kind of masks?
Right. So the question is, what problems have I seen with masks? Yeah, so masks have caused a lot of problems in people. They've caused exacerbations of the rosacea that you saw. They've caused some acne underneath. There's irritation. Um, yeah, masks have been a problem over the last couple of years. So if you're experiencing a facial rash and you've been wearing your mask, when you're out of your apartment, that's something which a lot of people are suffering from.
Question that comes up is about the insurance. Here, or some supplementals you take, some you don't.
Right. So the question is about insurance. So everyone, here is probably either on Medicare or a replacement Medicare or Medicare in a secondary, um, and pretty much any visit and procedure that I have is covered by insurance. Um, in 9 years, well, you might get a bill if something is delayed in payment or wasn't paid, but I have to tell you that in 9 years, I've never sent anyone a bill saying, and we haven't paid it. So relax about that, but your insurance will cover everything. Yeah, I mean it's no one. No, I mean there might be your deductibles or your co-pays. Obviously, you have to take care of that, but as far as it not covering the visit itself it hasn't been an issue.
This is an identification. Are carcinoma always colored in different colors? Or can they be?
The question is, do all skin cancers have a color to them? Um, and the answer is no. So you can have melanomas that are not dark, because they're kind of rare. So and then the other kinds of skin cancers, they usually are red. They have some redness to them because the body is trying to fight them. That's part of it, and or they have blood supply. But initially maybe they're more skin colored. So there's a wide range of appearances.
Noma and a melanoma.
So what's the difference between a carcinoma and a melanoma? Carcinoma just means cancer. So there's no difference between a carcinoma and a melanoma. A melanoma would be a carcinoma of melanocytes, but we just call it melanoma.
Thank you.
In the back. In here, did you hear it?
What causes hair loss?
Oh, hair loss. So what causes hair loss? Lots of things cause hair loss. If you're experiencing hair loss as an older person, it can be natural thinning of the hair. That being said, if it's focal, or if it's been associated with disease, that can cause the hair to fall out temporarily. Um, then there's thyroid problems, hormonal problems, immune problems that can all contribute to hair loss. It's very complicated, but in most cases, especially in older people, it's that your hair will change in its thickness as time goes on. You probably have noticed that already. Fortunately, I can tell women that they're most likely not going to go bald. It's very, very rare. Men, on the other hand, well, we know. Yeah. I missed the question. Say it louder. Right, the question is, do I treat or deal with lymphedema? Lymphedema is a swelling of the legs that can result after surgery or infection. And the answer is yes, but if it needs any kind of compression or any kind of real wound care, then that's something I don't deal with. Yes. So the question is, if you get shingles, can you get it again? The answer is yes. and that means you're unlucky, or your immune system is dipping again. But I would say most people, if they get it once, it's less likely they're going to get it again. So if X% of people get shingles, and the chance of getting shingles again is X divided by 4 or something. It's much less common.
These mats in the exercise room, and I always go and take 2 pieces. I don't want to catch any kind of a skin infection on my head, but maybe that's not. I don't have to do that. Maybe I can just put it right down on the mat.
Yeah, the question is, can you get any kind of skin infection from the equipment in the gym, whether it's mats or the weights and things like that? I think it's just prudent to clean them. It's probably unlikely, but
put the paper down.
it's just prudent to clean them before and after you use it. So the question is, well, it turns out that because I'm at Extension or Amita or Resurrection or whatever it's been over the last 20 years, yeah, I have access to those records. I can put the information in and pull that up. Yeah. Yeah.
Is alopecia a skin problem?
The question is alopecia caused by skin problems. Well, alopecia is a skin problem because it's the scalp that's losing the density of the hair. And as I said, there's a lot of things that can cause it. It can be immune problems, it can be health problems, medications, and problems with hormones. So it can be a skin problem in itself, or it can be caused by more systemic problems.
I don't know if you get into cosmetics, but they advertise the CeraVe, which I use, and they have an AM and a PM, and then they have the moisturizer that you want. What do you think of CeraVe?
So the question is, what do I think of CeraVe? Well, okay, so I get asked a lot, what's the best moisturizer? And that's the question I'm going to answer. Because it turns out that the best moisturizer that you have and can use is the one that's right now in your bathroom. Because you have it and you're going to use it. The difference between a CVS moisturizing lotion and a CeraVe or Eucerin or a department store, cosmetic area moisturizer is less important than the idea of using something or nothing. So I very rarely, I never recommend moisturizers, but if someone says, hey, I use CeraVe, that's great. CeraVe is a great one. But how does it compare? I would say it compares fine with anything else you're using or someone else is using. All right, one last question. Do I treat eczema? Yes, I treat a lot of eczema. So what kind of eczema do older people get? Well, they could have had eczema their whole life, or they could have had eczema on the hands for decades, or they, or they could have eczema that's a function of dry skin, whether it's on their legs or their body. So yeah, I treat that. Okay. All right, well, I'm done, and I have patients to see today. But
thank you, Doctor.
You're very welcome. I do appreciate you having me here today. And I did bring some samples that I think there's probably enough for everyone. But if someone doesn't get, then let me give you, yeah. And then next month when I come, I'll put a little bag by your door. So if you don't get one today, just let us know and I'll bring one next month. Thank you.
Thank you.
Thank you, Dr. Phillips, for coming out. If you have other questions and they didn't get answered, or you think of something later and you really want to ask the question, email me, call me, stop by. I can get a hold of him and pass your question